So welcome everyone to the March joint session of the VLC, establishing partnerships and settings that conduct high volume of viral hepatitis testing to improve reporting and data quality, made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Isabella Chuga. I use she, aya pronouns, and I am a senior manager on the hepatitis team at NASTAD. I am joined today by the moderator of this session, Dr. Mona Doshani, medical epidemiologist with the clinical interventions program team at the CDC's Division of Viral Hepatitis, Annette Gaudino, director of the policy strategy with Treatment Action Group, and Jen Braun, epidemiologist, hepatitis C surveillance with the Office of Infectious Disease at the Washington State Department of Health. So today's format, we will dedicate the first half of this session. Oh, folks can put themselves on mute. Yeah, okay, thank you. Where was I? Yes, all right, so the session for today will begin with presentations from Annette and Jen, followed by discussion Q&A, which will be moderated by Mona. So in the meantime, please use the chat box to introduce yourselves and your jurisdiction and to ask our presenters questions. So I also want to thank our colleagues from the surveillance team from Washington's Department of Health for making themselves available to answer any questions and for their contributions to this session as well. So with that, I will turn it over to Annette.
Thank you so much, and thank you for having me today. Give me just a moment to start sharing my screen. Everybody see my slides okay? Great. So my name is Annette Gaudino. I'm Director of Policy Strategy for Treatment Action Group based in New York City. And I'm going to go over some of the recent regulatory changes to HCV diagnostics that you may have heard of. So this is going to get a little wonky, a little weedy, but hopefully it will give you a clear picture of what's happening on the regulatory side and what we can expect as health departments and communities that are trying to expand and scale up diagnostics as we try to progress towards viral hep elimination. So the things I want to cover today and things I hope we learn are, as I'm saying, explaining the changes in FDA approval requirements for HCV diagnostics, understanding the status of existing point-of-care molecular diagnostic platforms and assays, both in the US and abroad. I want to discuss diagnostics in the context of elimination efforts in New York State and New York City, because that's where my experience comes from, and also share some advocacy efforts that are just starting to get off the ground and some resources that might be useful for you all in your work. So down classification, explain. This is the TLDR of down classification. So the FDA classifies diagnostics, the assays and the machines and the platforms based on several criteria. Really boils down to the complexity of the assay and the training involved, the staff education required to run the test and to get an accurate result, and also the impact on the patient of that result, actionable results. So for example, a diagnostic test result that results in a diagnosis that's a lifelong chronic condition, if not treated, like viral hepatitis, is going to be classed more stringently and regulated more stringently than a test that diagnoses a condition that can easily be treated with existing treatments. Now with HCV, the advent of highly effective, easy to take, well-tolerated oral direct-acting antivirals, along with, all the work that's being done towards elimination, and also the release of the National Strategic Plan, really kind of had set the stage to down-classify FDA requirements for HCV diagnostics. And I've sort of cut and paste kind of like the key text from their order, and there's a link there to their order. And this happened in November of 2021. You should understand, however, that this is something that goes way back to like 2016, 2017 is when people first started talking about this, at least on the CDC side. And to give you a sort of broader context of like regulatory processes and how long these things typically take, typically the FDA is about 5 or 6 years behind the European Medicines Agency in terms of approving new diagnostics and making them commercially available. So this is separate from, probably what you're most familiar with as local health departments, which are CLIA waived, lab developed assays. Now, another thing that kind of slowed the process and added to the length of the considerations around changing regulations for HCV diagnostics is that the viral hepatitis is regulated within the branch that also regulates HIV. And because of all the things that come with HIV, stigma, discrimination, again, a lifelong condition, which obviously are, also broadly and generally true for viral hepatitis, and specifically HCV, it's a historically cautious branch. So even when they see things that are approved and being used outside the US, they're still gonna, be very, very cautious in how they approach evaluating and regulating commercially available products. So the other thing that's really important to understand is that the product developers themselves have to be proactive in this process. FDA does not go out and solicit submissions for approval. Industry partners and manufacturers have to want to enter the US market with their products, and so have to want to go through the regulatory process. And that regulatory process comes with costs and with some burdens. So when things get down classified, one of the significant things that happened is that from going from class 3 to class 2, class 3 fees that manufacturers must pay in order to the FDA, user fees in order to be evaluated, or could be in the millions of dollars. By reducing the classification, bringing down classified to class 2, now the cost to the product developer is more in the range of like in the hundreds of thousands of dollars. That's not a barrier to large manufacturers, but it can be a barrier to startups and smaller companies, and it also can be a barrier to companies that, for example, have affordable products that they sell mostly in low middle income countries. So think of like generic, the equivalent of a generic manufacturer for small molecule medicines. And here I've included a link to a webinar that TAG and NVHR co-hosted with, that featured Ann Gaynor for the Association of Public Health Laboratories, that kind of helped orient us to all this stuff. There's a lot of different assays and different products in the pipeline, but things are slow moving. So TAG does have a pipeline report. We had in earlier years producers report every year, but we haven't updated it since 2020 because there hasn't been a lot of action, frankly, in the pipeline, because there's the market outside the US is actually quite developed. So really in the US, it's about getting manufacturers to engage with regulatory processes to bring their products into the US market that are already being used either in Europe or in low middle income countries. And this is an example of sort of how we break down in our pipeline report, like a typical like product profile and sort of snapshot for a commercially available product. And like I said, our pipeline also goes back to things that aren't approved. I'm highlighting the expert assay because the Gene Expert platform, which is a multi-disease platform, it's very widely used for TB and HIV around the world. They also have hepatitis B assays. Has a virtual monopoly in some countries, and the company is US based. It's Cepheid is the company. We also use this platform for rapid molecular diagnostics for COVID in the United States. And in fact, the US government invested quite a bit of money to help sort of pioneer and get development rolling on this platform, and purchase some machines to expand testing during the COVID response. So now I'm going to turn to New York City and New York State as a little bit of a case study of how elimination efforts, surveillance, and testing kind of all can be leveraged together to expand testing, to bring down barriers, and potentially even perhaps play a role in bringing some of these technologies to the US market and to patients and to communities in the US. So back in around 2016, a community-led multi-stakeholder process to do HCV elimination in New York State was convened that generated some draft recommendations in close partnership with New York State, but was not officially sort of sanctioned by the state. Through some advocacy, we were able to engage the governor's office and start a more formal process that was really in close collaboration with New York State around 2018. That also came with some state funding. And I'll never forget our very first meeting in Albany. We were all sort of getting together. We were organized into some work groups. There was a data and metrics work group that I was participating in. And part of that work group, there was folks from New York State DOH, surveillance and epi, and they were New York City folks. And they were in the same room together. And at that time, New York State is a home rule state. At that time, New York City had developed some pretty robust data systems and reporting systems. We had been able in New York City to report negative RNA results, and we also had developed, or they had developed, a very robust deduplication algorithm that also helped with data quality. And these are not things that we had in what we call rest of state in other state counties. And there was a lot of variety in terms of capacities and data reporting procedures in different counties. But now you had the city folks and you had the state folks together in the same room, and they immediately started talking and collaborating and sharing technology. And that process, once that got rolling, really was able to set the stage and to be built upon. Sort of parallel to that, there was, because we have the Wadsworth Center based in New York State, which is a center of excellence, and has great capacity to develop really robust lab-developed tests. I don't actually. I'm sorry. I should have looked back on my notes on some of this, because this project was started pre-COVID, and some things have gone into the pre-COVID memory hole. But there was a pilot project to look at the potential and the feasibility of integrating dry blood spot testing into some of our states in rural counties, and to see like what the benefits were, what are best procedures, sample handling, how should we handle samples to get results, how do we deliver results to peer workers who can then share them with the patients, what are all the best practices. And that got off and running around that same time, around 2018, 2019, and really learned a lot. And so I think that's a good example of how you can sort of start small and start modest and leverage existing institutions and capacities in your jurisdictions, with the aim of going statewide with stuff, but starting small, starting local, and really addressing things to local needs. So one of the things that was sort of instinctually understood when they started this pilot, but was really borne out in the development of this pilot, is that dry blood spot, where samples are collected and then mailed to Wadsworth for analysis, and then results delivered back to peers who would then follow up with patients, is that it's really well suited in settings where there's a lack of transportation and providers and labs are few and far between. But dry blood spot probably isn't something that has a lot of added benefit in a New York City setting, which is very dense, both with labs and providers, and that there are different challenges and different opportunities in a dense urban setting versus a more spread out suburban, exurban, or rural setting. So I hope that gives like kind of like I said, like a bird's eye view and an overview of sort of like the regulatory picture. I'm happy to answer some questions, and I'm actually going to come back to some opportunities for advocacy based on some of the where we are now with the access to actionable, confirmatory testing for HCV in the U.S. But I really always like to, whenever I'm in a room with local health department folks and epi folks, I just always love to underscore the power of data for advocacy. Heat maps, heat maps, heat maps. Whether it's talking to city council members or state assembly members or federal appropriators about unmet needs, unmet funding needs, They want to see what's happening in their constituency, and there's nothing more powerful than a map. And the power of maps is sort of additive, that if you have a map that's showing disease burden, infectious disease burden, and you can correlate it with a map that's showing poverty and social economic status, or race and other demographics, you are really starting to tell a story, a very powerful story. And that's what you need to be able to do, what advocates need to be able to do to really plug gaps and bring forth their best advocacy to provide the resources for you all to do your work to the best of your ability, and to also scale it up and to be ambitious with it. So I know it can seem sort of like, where do you begin as epi folks and as data folks? How do you engage with community advocacy? What's your role? I always think of it as, your role as public servant is to report back to the public the data that you are collecting, and analyzing on their behalf. So this is information for the public, and you don't have to interpret it for advocates. It's up to advocates to tell stories with your data, but you absolutely have a very critical role to play in data presentation. And always when we're talking about these issues, let's not forget that we're talking about people. Yes, numbers, maps, absolutely important. We need them to tell our stories, but we're telling people's stories, the stories of human beings. And so poverty, stigma, and discrimination can't be separated from the stories that we're trying to tell around viral hepatitis and the needs that we're trying to meet. And we have to always bring that to every aspect of the work that we do. So if any of this is interesting to you, if you have want to learn more about how we can try to expedite FDA approval of tools that are available outside the US, if you want to learn more about some NIH funding opportunities for point-of-care molecular diagnostics, that it's a 3-year grant that's actually out there, and that is out and serving some communities and is still open for applications, and you want to engage in some potential advocacy with manufacturers, with funders like the NIH, and with other stakeholders, I really invite you to join the Viral Hepatitis Diagnostic Working Group that's co-convened with TAG and the National Viral Hepatitis Roundtable. You can email me at this address, or Adrienne Simmons at NVHR, and we can get you on our email list. We meet monthly. Our next meeting is next Thursday, 3 p.m. Eastern Time. And we also do a lot of sharing of papers and research and just conversation on our listserv. And it's really a great space that we're trying to create, and I'm very excited about what we could potentially do together this year and in the coming years. I'm going to flag some additional resources. Sometimes it's helpful for epi folks to drop in and kind of get, sort of do some deep dives and understand the more clinical perspectives around the infectious diseases that you're tracking. New York State has some really good, free, easy to drop in and out of webinars and courses. They're also archived, so you don't have to do it on their schedule. You can dive in and look at archive recordings. Hep Elimination is a project of National Viral Hepatitis Roundtable that is a scorecard and a rubric that reports back on the status of state-level elimination efforts. So you can look up your state and see how you're doing, and really need to be leveraging all the opportunities that elimination planning processes provide to work for and with other stakeholders to improve your resources and the work that you're all doing. And then I also wanted to highlight the New York City Viral Hep Elimination Plan, because I think it has some good metrics that might be useful if you're engaging in elimination processes, or if you simply want to share with partners and other stakeholders in your jurisdictions who are starting their elimination planning process as per CDC grant requirements. So I hope that wasn't too much. I hope that you found that useful. I look forward to conversation and discussion. And please don't hesitate to reach out to me after this session if we don't get to your questions, or if something occurs to you. And my slides will be available after the session. And I'll stop sharing my screen now. Hope that was good on time.
Perfect.
All right, thank you so much, Annette. Isabel, should I go ahead and share my screen and get started?
Yes, thank you.
Great. All right. Okay, I think you should be seeing my first slide. Awesome, thank you. All right, hi everyone. My name is Jen Braun. I use she, her pronouns, and I am a hepatitis C surveillance epi within the Office of Infectious Disease at Washington State Department of Health. And I was brought on to Washington State to support Hep C from mainly an informatics standpoint, but I've been really fortunate to be able to wear many hats within the surveillance program since then. So today I'll be providing a few examples of partnerships that we've been able to establish across different entities that have helped improve our viral Hep B and C reporting and data quality. And I'll be ending with a few notes about data quality processes on our surveillance team. So much of this information I think will likely feel familiar to many, but I'm hoping it will still be helpful to some and trigger some good discussions and feedback for us today. All right, so to start off, I figured I'd give a quick overview to provide some of surveillance within hepatitis surveillance within our state to help provide some context for today's presentation. And so Washington State is a home rule state as well. Public health authority lies within with our local health jurisdictions, or LHJs. And laboratories and providers in our state are mandated to report directly to LHJs, with the exception that ELR submitters are able to send data directly to us at the state, which feeds directly into our surveillance system, which is shared by state and local staff. And another thing to note is that ELR reporting is currently not mandated in Washington. So I'll head into kind of an overview of the main staff on the hepatitis B and C surveillance and prevention teams, starting with hepatitis C. So in our surveillance team, we have one hepatitis C surveillance coordinator, we have 2 epidemiologists, 1 health services consultant currently who provides the majority of our data support. And we're currently hiring 2 more health services consultants and 2 more EPIs, which is really exciting. On the hepatitis B side, for surveillance, we have a surveillance coordinator, 1 epidemiologist. And actually that's the team, 1 surveillance coordinator and 1 epidemiologist. And so in terms of funding, our hepatitis B and C surveillance and prevention teams actually sit in different offices so the funding for each condition does look slightly different. So on the hepatitis C surveillance side, we have both general, state, and federal dollars through the CDC's 2103 grant that fund our staff, but most of the Hep C surveillance work is funded through state dollars. From the hepatitis B side, they do not receive 2103 funding currently for additional activities. And instead, they use a combination of communicable disease epidemiology, general state fund dollars, and CDC enhanced detection expanded COVID-19 funds to cover Hep B specific surveillance positions, noting that the COVID-19 pandemic has significantly impacted public health's ability to identify and reach communities that are marginalized and are at higher risk for hepatitis B and Delta. And we also have prevention teams for both conditions as well. So on the hepatitis C side, we have an adult viral hepatitis C prevention coordinator, 3 disease intervention specialists, and a viral hepatitis testing coordinator and a drug user health coordinator as well. And on the hepatitis B side, there is a coordinator as well as a perinatal hepatitis B prevention program coordinator. And in terms of funding for prevention on the BNC teams, they both use a mix of federal and state funds. And for hepatitis C prevention, similarly to our surveillance staff, some 2103 funds do go to help support prevention work. And then have a couple of notes here on what hepatitis B and C surveillance data flow look like within our state. Our surveillance system and registry is called the Washington Disease Reporting System, or WDRS for short. It is a MAVEN system, and it is currently shared with other notifiable conditions, excluding HIV and STI. And I have a flow chart here kind of demonstrating kind of the main major pieces of our surveillance system. But just to note that we have ELR data that we receive that goes through, is able to go through a standardization process. And in addition to that, our team is able to bulk import data from other electronic data sources after we run some data transformation. And a third source of lab and case reporting that occurs within our system is through manual entry of our users and investigators, which end up being usually fax labs that are not received via ELR. So now I'll be heading into some of the partnerships that we've already established, starting with electronic lab reporting. So these will be our licensed and certified laboratories who submit via electronic lab reporting. And we do have a dedicated team who onboards laboratories to submit ELR via HL7 messages, which does require iterative testing. And so some of the barriers of this is just that onboarding is time intensive because of that iterative testing and back and forth communication during that time. And there is a lack of capacity on both the state and the laboratory side as well. But the ELR team has grown rapidly recently in response to the pandemic, and have recently restarted efforts to onboard labs to ELR for non-COVID conditions, which is really exciting. So finally, just a note here that not all labs, again, submit electronically because it's not mandated within our state. And so in some cases, we've been able to pursue other options, which I will cover in the following slides. Starting with MultiCare, which is a laboratory that is part of a regional healthcare system within our state and includes hospitals, clinics, and urgent care facilities. And so what happens now is we receive monthly electronic flat files of lab reports. They come in as basically Excel spreadsheets that are transformed and imported in bulk into WDRS by our surveillance teams. And so kind of the why we pursued this was because they're not currently an ELR submitter, and they do test in higher volume. And so the mass import that's facilitated by our team really relieves a lot of the manual entry burden on LHJ, since they don't have to receive those individual faxes and manually enter the data into the surveillance system. And additionally, we were already receiving a flat file from MultiCare for HIV results, which was a process that had been in place for years. And so we just made a request to add Hep C and Hep B results to that existing process. And we began receiving hepatitis results from them in December of 2018. And so in terms of barriers, they were pretty limited because we were just adding on and piggybacking on to an existing process. But it did require staff time to create the code to transform and import the data into our surveillance system. So that's it for partnerships that examples of partnerships we already have established. And so I'm going to go into some of the partnerships that are in progress. Starting with Ideal Option, who which is an organization that provides medication-assisted treatment for opioids, alcohol, and other substances. They have 70 locations in 10 states, and there are 24 clinics within Washington state that span 14 of our 39 counties. And so they do conduct screening for hepatitis B and C and other infectious diseases as well. And so we're hoping to, easily obtain and efficiently obtain lab reports and case data from our ideal option facilities because they currently aren't an ELR submitter, and they do have access to patient medical records. So we're able to obtain case investigation data in that way. So they are a low to moderate volume reporter, but again, mass important to WDRS facilitated by our team will really help relieve the burden of manual entry for our local health jurisdictions. And in addition to that, there's actually just one ideal option staff member as our point of contact who is responsible for faxing all of the screening results to local health jurisdictions and fielding all of the phone calls to provide additional case information. And so I don't know if ELR, having them submit via ELR is possible, but right now the ideal state is really for us to be able to facilitate import of lab and case data to relieve burden on, in this case, not just our local health jurisdictions, but for the staff at ideal option as well. And just a note here that initial discussions surrounding this work began in October of 2021. And so some of the barriers in getting this work implemented has been kind of staff capacity, I think I'd say on both sides at the state and ideal option, playing a lot of phone tag right now, but I'm optimistic that things will progress. It's going slowly but surely. I have some notable projects we wanted to mention today that are currently in progress. We have the lab survey for the 2103 grant that I think many of you all are very much aware of. So in addition to obtaining information regarding reflexive RNA testing, this will allow us to identify other hurdles and gaps in reporting, identifying points of contacts and creating relationships with our lab partners, and encouraging onboarding to ELR as well for those who aren't submitting electronically already, and seeing how we can provide support to them. Another project that is in the works is electronic case reporting, which is extremely exciting because this will really help improve some of our provider reporting and case completeness among our Hep B and C cases. And so we will be starting off with COVID. That's been identified as the priority before expanding to other conditions like hepatitis. And so similarly to the ELR team, our state, we do have a dedicated team working on implementing electronic case reporting. And that team has grown since the pandemic because they've been able to receive CDC funding to work on this. All right, and to wrap up today's presentation, I'm going to talk a bit about data quality assurance. And so some of the processes that exist within Washington state are currently a bit slim, but we really are looking to expand as our team grows. And so currently we do closely manually review acute and perinatal cases prior to submission to CDC on a weekly basis. Our chronic cases are currently being reconciled yearly just due to volume and again, staff capacity. And so we do QA, through SAS with limited manual review. But again, as our team grows, we hope to do this more on a quarterly basis. And in addition to that, we are able to easily query our surveillance database in real time and identify and correct issues systematically, which is great. So, if we discover or are notified of a potential issue with ELR data, for example, within WGRS, we're able to query to identify whether it might be a one-off or maybe more of a widespread issue. And finally, some takeaways from that we thought we would talk to or speak to during today's session is really, as always, COVID-19 impacts is at the top of the list for our team. And I know many others, or everyone, basically, COVID took away resources and resulted in some turnover on our teams. And, informatics related projects always take longer than expected. And the staff turnover during this period really didn't help and kind of exacerbated this because it really doesn't help when you lose people who hold institutional knowledge. But on the other hand, COVID has also provided us with opportunities, or at least expedited certain opportunities as well. Exhibit A and B, being our now larger ELR and electronic case reporting teams. And so for us and our team, in terms of improving overall reporting, ELR really is end game because of volume and for other reasons. A lot of our case reporting really is identified through lab reporting. So getting everyone to report via ELR will be great, but we know, this isn't always possible. So creativity really helps. And, we've also have seen that for some labs, ELR sometimes is the only option, which is unfortunate, but kind of the reality, depending on the facility that you're working with. This is a big one that I've learned as my short time as an epi is that leveraging existing resources wherever possible is really important, especially with HIV in our case. With multi-care, it was really helpful that the HIV team already had that existing process to receive that flat file data. And so from what I had seen when I first started with DOH, kind of getting that implemented for hepatitis really seemed pretty painless from my perspective. And then finally, with data quality assurance for our surveillance team, I've seen that being able to query our surveillance database using SQL in real time has just been extremely helpful. All right, and I think that's all I have for you all. Happy to take questions in a bit. And I have on the screen here the general email for our Washington State Hep B and Hep C surveillance teams. Figured it'd be easy to have a one-stop shop for everyone. And if there are any prevention related questions as well, we're happy to funnel those to those on the prevention team. Thank you.
Thanks, Jen, and thanks, Annette, for such wonderful presentations and sharing a lot of wealth of information for everyone. Isabel and Annette have shared some links on the chat. These are useful resources for you as well. If y'all have any questions, please do use the chat function for questions for Annette and Jen. They would be more than happy to answer them. I have a question actually also for Annette. So I'll start off with one and then we'll see the chat box also later on. So Annette, could you speak a little bit about the opportunities for the hepatitis diagnostic work group to work in collaboration with jurisdictions? And also there's a second part of this question. We always talk about successes. So could you talk a little bit about some of the challenges or some of the barriers that you encountered, or what would you have done differently that you would like to share with jurisdictions?
Sure. I actually take that second question first because I think,
Sure.
yeah, it's really important to learn from our experiences. And and not only highlight successes, because it can be a little bit intimidating. I think everyone's feeling, especially after the strain that we've all been put under and our systems have been put under for COVID, where do we even begin to scale up the work that we're doing for viral hepatitis? How do we get on an ambitious track when it comes to elimination? And I would say for the New York State, New York City example, New York State, it's one of the larger states in the country with one of the bigger populations, and we sort of have a demographic or a population split in which about half the state's population is concentrated in one metro area. So that determines a lot of how public health is delivered, and it also presents an incredible challenge to doing state-based work. Because how do you coordinate and communicate across such distances and across such diversity of communities, right? So I think if we had it all to do over again, and you're seeing it now in this phase of elimination that we're doing, I think we would probably take a regional approach to things in which we would try to coordinate and organize regionally to have conversations, have convenings, share resources, and try to build on that level. Not to say to not have a statewide objectives or picture in mind, but in terms of real collaboration and regular communication, I think if we had taken a regional approach, we really would have benefited from that. And like I said, now that we're starting a more formal planning process, and we have some recommendations that we'd like to see advanced, there are regional planning sessions that now the State Department of Health is convening. So I think we all kind of came to the same realization around the same time. So that's just one example, and I'm sure you can all think of things from your own jurisdictions. Another one, just quickly, that I'll highlight, and this is again reflective of various the specific conditions in New York State, is that the hepatitis C community was a little bit more organized in their advocacy and more vocal in their advocacy back in like 2016 when we started thinking about elimination or looking at viral hep through an elimination framework. So on the state level, we didn't have integration and moving forward as viral hep. We really had a statewide hep C process. In the city was where you saw it was across the hepatitis. So I think that's something too. I'm not sure if we could have done it any differently at the time, but that's something that if we were starting today, we obviously would do that differently. In terms of opportunities for local health department folks, I mean, I just really think it's important for us to convene and to learn from each other, and to find out what the barriers are that we could be overcoming. Because one of the things that I think is kind of tricky when you're thinking about something like how do you bring new point of care diagnostics into spaces is sort of like, what problem does that solve? It's not technology for technology's sake. It's what specific problem does it solve? And when you think about why some of these tools may be used more broadly in low and middle-income countries in under-resourced settings, is because they confer certain advantages in those settings, and because some of those settings lack some of the infrastructure that we may have. So we have a pretty well-developed commercial lab infrastructure. So it can sort of seem like, well, that'll take care of everybody, but we all know that it doesn't. Whereas in a low-resource setting, they don't have that commercial lab infrastructure, and transporting samples to a national lab can take days, if not weeks, and there's challenges with sample handling. And there's no good way to reconnect with folks once they've, had a blood draw and things like that. So we really want to try to approach regulatory issues and technology issues more from what needs are being met and less from like, what does the tech do? I think that's something that we're really committed to at TAG, and it's something that we've actually had to teach some of our partners who are more on the technical side or who are on the industry side, who like to sort of tout like a feature like, returns results, in less than 60 minutes. Well, no one's going to wait around for 60 minutes. It's more about how are you returning that? How are you reporting that result to payers? How are you reporting that result to the public health system? How are you reporting that result to the provider, the trusted provider who has the connection with the patient and the client, who can then turn that result, as we were saying earlier, into something actionable, which is care for that person. So I hope that wasn't too rambling. I hope that that makes sense in terms of answering your question about opportunities. Is to say that, local health department folks and epi folks, you have expertise and you know things that we don't know, and you can help us identify more gaps and unmet needs that we could be advocating for.
Thanks, Annette. Yeah, I think that's really useful. Jurisdictions, you've shared the information also, so please do contact Annette if you'd like to be part of that group, work group. We at CDC also are going to be contacting Annette because we have a hepatitis diagnostic work group here, and we're doing also similarly finding out, what's really happening internationally and what we can do in the United States. We have a question in the chat box for Jen. It's from Nicola. It says, thanks for your presentation. When your team performs a manual review of acute and perinatal cases for data quality, can you give examples of what you're looking for, or examples of what you can find that requires correction or an update?
Yeah, thanks, Nicola. It's a great question. So to briefly summarize, once a local health jurisdiction is done with their case investigation, it gets punted to us at the state for review. And in general, what we look for is reviewing for things like verifying that the symptom onset date and diagnosis date and the lab history looks to align and make sense. Additionally, from the hepatitis C perspective, as well as hepatitis B, but what I personally do is will review the lab history that we have for that individual thoroughly to make sure it aligns with the CDC case definition. And, sometimes there's a bit of back and forth where I have to reach out to investigators to get clarification on perhaps a lab that they noted in their case notes, but is not present in our laboratory section. And in addition to that, for hepatitis C, we do run some QA processes to help further identify potential acute cases for priority in investigation as well.
Thanks, Jen. Does that answer your question, Nicola? Okay, perfect. Thank you. Right. So I have another question for Jen, actually. Jen, you talked a little bit about building partnerships. You talked about some in progress, some that you've established. Why do you think these partnerships are successful? And what do you think, what suggestion would you give the health department that who are beginning their partnerships or want to keep holding on to those partners, which they have already established, but due to COVID or other issues, they're sort of like lapsing out?
Yeah, definitely. I'll kind of have a couple of thoughts on that, but also welcome my Washington State colleagues who are on the line, which include a couple of our managers, to chime in as well if they have anything to add. But from what I've seen as kind of a self-proclaimed newbie, is that kind of leveraging resources and existing partnerships from other programs like HIV especially really allows our kind of requests to help to create partnerships and improve our reporting and data quality. Leveraging those existing resources to these partners helps make things less burdensome for them. For me, I feel like persistence is really helpful, and just being kind and understanding during communication, since we're all in the same boat, especially in the age of the pandemic, where we want to do what's best for our population, but are all struggling with workload. So I think that's kind of my 2 cents. Did that kind of answer the meat of your question, Mona? Great.
Yes, yes, it does. It does. Thank you. It's really important to hear that on how do you sustain it. And then and a question which I have for both of you, actually, since we're still waiting for other questions in the chat box. It's a little bit about, we hear about the impact of COVID and how that has affected like state health departments. But I want to hear a little bit about, from Annette and from you, Jen, like what are some of the resources that were useful from COVID that helped to, which you have leveraged to support some of your work? So if you could speak to a little bit about that. I mean, I'm just curious about that. I know you mentioned it a little bit, but if you could elaborate a little bit on it.
Jen, do you want me to jump in or do you want to go first?
I could go first and I'll hand it over to you. Just to reiterate that in terms of ways we've been able to leverage kind of the resources out of the pandemic, again, just seeing that the ELR team has been able to expand because of that. And so we're really looking forward to having more capacity to onboard facilities to electronic lab reporting for our non-COVID conditions. And again, highlighting our electronic case reporting teams that they were able to grow due to funding that came out of the pandemic. And outside of that, I think I've been able to leverage kind of some of the relationships that the ECR team built with other jurisdiction who already have electronic case reporting implemented for those jurisdictions that use the same Maven system. Kind of seeing the demos of how their system works has been really helpful in informing kind of what we can do on the hepatitis surveillance side to improve our registry. And then other than that, there were some cool data entry tools actually that came out of the COVID response that I'd really like to leverage when we have the time. For example, I did not realize that there is a tool where you could scan labs and it has the ability to kind of pick out different pieces of information and grab the text so that someone doesn't have to, go through and type information into our surveillance system. And so that helps a lot with kind of data integrity in that way, because it helps mitigate some of the mistakes that, one can make if you're just staring at tons of labs all day trying to get them entered.
That's great.
Yeah, I'll kick it off to you, Annette.
Yeah, and sort of building off of that, I think the biggest sort of opportunity that came from COVID was a conceptual shift in two ways. One is what you're talking about, Jen, is sort of like people finding or discovering or integrating electronic and digital tools into the work that they were already doing, right? It's because necessity was the mother of invention, and really integrating electronics, record keeping and data handling, and developing robust protocols around that, I think is something that we all saw happening at quite a quick pace as a result of COVID. And I think a lot of those will lead to permanent changes that will be to everyone's benefit in terms of streamlining a lot of processes. Of course, those come with challenges. We want to make sure that people have access. We want to make sure data is protected. But I think overall, it's probably more beneficial than harmful or negative. I think the other thing it kind of did, and this is just me, talking as an advocate and as an activist, is that it was this incredible like public education about the importance of diagnostics in public health, and like really like technical things about, people understand now what a self-test is. People have heard of antigen testing, and they sort of have a general sense of the difference of different kinds of tests and what different kinds of tests tell you. And I think we couldn't, if we had tried to do a national education program on like, to this level of understanding of like really key concepts around diagnostics and just a general understanding of some of the technical aspects of diagnostics, we couldn't have done it. I think everyone, again, was sort of forced to learn these things. And that's really to our benefit. Like, chronic hepatitis C is a perfect example. A lot of times our peers and our frontline workers, are really having to explain to folks why you need to come back for a second blood draw, what the difference is between an antibody what an antibody test, positive test result tells you versus an RNA positive test tell you. But well, the last 2 years, like I said, everybody's sort of had this classroom on a lot of that stuff. So I think that conceptual shift on like, wow, like diagnostics is a really, really important part of public health and an important part of my health as an individual. And here are some key concepts that I now understand that I didn't understand before, is again to everybody's benefit, and I think is really going to help our work going forward. And again, it also provides opportunities to ask for more and for better tools, processes, systems.
Yeah, that's great. We also got a response from Jen Braun from Washington saying that Washington access to other tools like Redcap. We've been trying to get access for years. The plug that I would also put in is the current need for loosening up the use of money that has come into public health for COVID to be more accessible to other programs. Yes, and we're seeing that as much as possible, that even for hepatitis, we're trying to include some sort of way to get money for COVID for programs too. And I think Jen also shared the tool, which is called Open Text. Is that right? Okay. Okay, awesome. All right, so do we have any other questions from jurisdictions on the chat? Let me check. I don't see any more questions. So just, I guess, is there anything that Jen and Annette, you would like to share as some of the lessons learned or things that you feel would be beneficial to talk about? I know you talked a little bit about what you would do differently, but anything in terms of any roadblocks or anything that you think they should look out to?
Yeah, one quick thing that may sound minor, but I think it's actually kind of important that I forgot to mention in my talk is that, in looking at the time it takes for our regulatory authorities to get diagnostic assays out into the commercial marketplace and accessible, to providers and to patients, is that it typically takes around 2 years from like a change, like a down classification, or I should say 2 years from an industry partner or a product developer to sort of engage with FDA and say, yes, we want to apply, and to start submitting samples, to those samples being reviewed, all the data being reviewed and assessed, and for a final like adjudication of approval, of FDA approval. And right now, we don't have any FDA approved point of care tests for hepatitis C. And as far as we know, we don't have any industry players who are, in the process of seeking that approval. So we're kind of in a hurry up and wait situation, and we don't know when that 2-year clock is going to start ticking. We really, despite these great regulatory changes, we actually haven't seen any real action on that. It's all theoretical at this point. So I just wanted to share that because I think it's an important, sort of milestone or timeline to think about, and that perhaps this is something that could inspire some urgency from community for some action. So yeah, thanks.
And Annette, we got a question in the chat from Emily. Is the diagnostic group looking at related tests that might be needed to work up, example, CBC, liver function tests, thinking of models like Combi Clinic in Australia and how we can implement in the United States?
We haven't started talking about other related assays, but certainly open to it. And I thank you for raising Combi Clinic. That's a really great example. They're using Expert in their work, the Gene Expert platform, and they also were doing some pilot studies with a company called Blink1, which has an interesting kind of open source, innovative tool that's has multiplex capabilities. So yeah, there's some really good models of care and interesting pilot studies out there, and totally agree with you that we should be looking very broadly at all like the diagnostic algorithm and the related assessments, and seeing what we can do to expedite that stuff. So love to talk about it more. And if folks can't make it to meetings or don't have capacity to join, please feel free to reach out to me individually and raise questions that I can bring to the group to carry forward. Thanks.
Thank you. That is an excellent question. We might also reach out to you, Emily, and our group also. I think there's some more questions coming in. Is the diagnostic group looking at younger ages for testing? This is something we heard from the perinatal exposure testings.
Yeah, that's a great question. I think we really need to look at CDC guidelines and clinical guidelines for some direction on that. I think, you know, we don't want to get ahead of guidelines, because also we have to make sure that we have appropriate treatments and that we're treating folks appropriately. So good question. I don't have the answer to that right now. Like I said, we haven't really looked at it, but definitely want to be working in coordination with guidelines development and appropriate standards of care.
Thanks everyone for your questions, and thanks Annette and Jen. Really appreciate your presentation, and thanks everyone for attending as well. You will see there should be a link of an evaluation survey in the chat box. So please do complete that. It's really important so we get better and be more efficient in what we can help out with as much as we can. Thank you. Appreciate it. Bye. Thanks, everyone.